This video demonstrates our technique for arthroscopic repair of a posterior glenohumeral capsule rupture with concomitant anterior and posterior labrum detachment. The procedure is performed by Dr. John Cristofretti at the Allegheny Health Network in Pittsburgh, Pennsylvania. Dr. Dorr has no financial disclosures. Dr. Cristofretti is a paid consultant for both Arthrex and Breg. A few pearls when approaching a case of posterior capsular injury. It is important to establish the anterior viewing portal first to enable precise placement of the posterior portal. A 70-degree lens is helpful to completely view the posterior inferior pathology, and a spinal needle can be used as an additional working instrument to assist in suture passing. Viewing with the 70-degree lens from the anterior portal, the posterior capsular tear is seen. Our posterior working portal is established by spinal needle localization with the cannula placed extracapsular at the margin of the tear. The inferior leaflet of the tear is captured using a suture lasso through the cannula, and the nitinol wire loop is shuttled into the joint. A spinal needle is used to hold the wire loop. A tissue penetrator is then inserted through the cannula to capture the superior portion of the tear and capture the wire loop. A fiber wire is then shuttled through the ends of the capsular tear with the wire loop within the cannula. The fiber wire is tied over the outer surface of the capsule within the cannula to avoid any soft tissue bridging. Attention is then turned to the posterior labrum. The frayed edge is debrided using the arthroscopic shaver. The rim of the glenoid is then prepared with an arthroscopic rasp. A suture lasso is again used to pass a nitinol wire loop through the posterior capsule and labrum, which is held within the joint with the spinal needle. The posterior working portal is adjusted, and a fiber tape is shuttled through the tissues and anchored at the 7 o'clock position of the glenoid using a 2.5 millimeter push lock anchor. The sutures are then cut. The frayed edge is debrided again with the arthroscopic shaver, and there is a nice view of the posterior repair. The arthroscope is then moved to the posterior portal for repair of the Bankart lesion. There is considerable synovitis visible within the rotator interval. The arthroscopic probe is showing the anterior-inferior labrum detachment from the 5 o'clock to the 3 o'clock position. A tissue elevator and arthroscopic shaver are used to elevate the anterior capsule for reconstruction. A suture tack is placed at the 4 o'clock position, and the fiber wire ends are passed through the anterior capsule using a self-retrieving suture passer. These ends are tied over the anterior capsule. A suture lasso is again used to pass a wire loop through the anterior capsulolabral tissue and shuttle a fiber tape through the tissue. This fiber tape is then anchored at the 3 o'clock position using a 2.5 millimeter push lock anchor. The posterior portal is then closed using an absorbable suture. The humeral head is centered nicely within the glenoid. Thank you for watching our video.